Hi, everybody. Thank you so much for being here. This is Overdose Prevention and Reversal for Homeless Service Providers. I am Pike Long, and I will be presenting with Laura Maddox and an amazing panel of experts today. We are from the California Department of Public Health. So let's just give it a moment for everyone to join, and we will get started. This will be a recorded webinar until the point where the audience starts doing a Q&A. Cool. And it's great to see people from so many parts of the state. Thank you so much for being here. Next slide, please. All right, so I'll just say, my name is Pike Long. I use she, her, and they, them pronouns, and I am a housing and homelessness equity specialist here at the California Department of Public Health. And I'm going to turn it over to my amazing colleague, Loris.
Good morning, all. I'm Laura Maddox. I am a capacity building specialist, harm reduction specialist out of Office of AIDS here at CDPH. And I'm looking and seeing that there's folks still joining. So before we dive in, Pike, do you want to just give it like about one, because I still see folks are entering.
Yeah, absolutely. Let's just give it a second.
Okay.
And while we're doing that, we can let me see if I can peep the chat and see where we've got everyone. We've got Orange County in the house. Wow, we have a whole crew from Salvation Army. Thank you, San Jacinto, Humboldt, Santa Maria.
I see Riverside, City of Riverside. Good.
Riverside.
Good.
Very nice to see you all here. Costa Mesa, Ventura. This is so great. Thank you. Does it look like there's still a lot of folks joining, or should we continue?
I think we could start. I think we could kick it off.
Yeah.
Yeah. Okay, all. So we're gonna get started. Pike and I are we're very grateful that you all could join us today. And we're hoping you will all have some nuggets, some takeaway nuggets by the end of our session. So let's just get started with grounding and talk about what we hope to achieve today. Let's go with our objectives. Yes. Okay. So what we'd like to have happen today, we hope that improve your understanding of substance use and overdose crisis among people experiencing homelessness. And we're going to give you an overview of overdose prevention and reversal principles. Just a good one-on-one, a very quick one-on-one. And we're going to talk about the legal protections that exist in California. Usually when we do this work, when folks approach us and say that they'd like to get started, their number one question, like they lead with, it's not legal. What are the liabilities? We're going to take a bit of a dive into that. We're also going to discuss how programs can balance safety, sobriety, and harm reduction, and housing first as well, with overdose prevention and reversal principles. And then we're also going to have a lot of resources for you all, a lot of resources to take away. We will provide a copy of the slide deck. So a lot of links, resource links will be included in that for you. Next slide, please. Oh, a poll. Okay, we got a poll.
Yeah, we've got a poll. So we're hoping to get a gauge to just see where you feel you are currently at in regards to being prepared to intervene in the case of an overdose. So let's see, Molly. Okay, does everyone see that? And I just want to give a shout out to my colleague, Molly Lund, who is working tech support in the background. Okay, great. I see some answers coming in already. This is wonderful. I'm going to give it about 20 more seconds. And then we'll show the answers. All right, we're at 60%, 62%. Let's give it 10 more seconds. Oh, it's closed. Okay, great. All right, you want to show it, Molly? It looks like We are really all over the place. This is wonderful. So I see actually a solid number of folks who are at least somewhat prepared, and that is wonderful. But as we know, there is always more to learn. I like to say every day is a school day. So we are just so thrilled that you're all here. Let's go to the next slide, please.
Okay, we have a pretty packed agenda today, so I'm going to run through this quickly. First, Pike and I, again, will give you an overview of the relationship between homelessness, substance use, and overdose. We're going to touch upon the basics, and then we're going to have a really great panel discussion with folks who are already doing the work. And we'll allow, like, they're going to share like their experiences with overdose prevention, and then we'll also have a moderated panel discussion, and then we'll leave about 10 minutes at the end for Q&A for you all. And in the between time, when we're running through our presentation, if you all have any questions, please enter it in the chat. We will be scanning the chat for questions and use that as a good pause to get folks caught up. Okay, next slide, please. Let's get started. Okay.
Awesome. So thanks, Loris. I really like to start off by just grounding us in the basic premise of why people experiencing homelessness might be using drugs and alcohol in the first place. So if you could just, in the chat, go ahead and type why you think a person who is experiencing homelessness might use drugs. What are some reasons for that? Staying warm, coping, self-medicating, numbing, survival, PTSD, easing the pain, boredom, escape, mental illness, trauma, addiction, right? You guys know this. Safety. I love that somebody acknowledged that, right? These are really great answers. I see a bunch more coming in. Some people were already using drugs before homelessness. A lot of times people are afraid of sleeping outside without, when they have to actually sleep. That's right. So I know I'm talking to a really knowledgeable group of people, so we're not going to read every answer. But I really just like to start out by asking this question to help us remember as we go ahead that there are a lot of reasons why people make the choices that they do, right? So let's go to the next slide, please. So those of us who have worked in homeless services for any length of time understand that substance use disorders and homelessness can have a reciprocal and mutually reinforcing relationship. Using drugs can both allow a person experiencing homelessness to cope with the danger and trauma of being unhoused, and it can contribute to their inability to maintain stable housing if it gets out of control, right? So it should not be a surprise that people experiencing homelessness are also particularly vulnerable to fatal overdose. Next slide, please.
Let's see. So now we're going to get started with some data. We're going to talk about the data. We're going to talk about the problem. So the United States and California have both seen unprecedented numbers of fatal and non-fatal overdose in recent years. In 2001, the US lost over 100,000 people to fatal overdose, the highest ever recorded, a record. So California alone accounted for nearly 10% of these deaths. And something that we'd like to note as well, while we are talking about opioids, we're talking about synthetic opioids, fentanyl. It is important to note that psychostimulants, stimulants with abuse potential, have factored into the rising death toll and at a rapidly expanding pace alongside other drugs like fentanyl. So these drugs can include meth, methamphetamines, MDMA, also called Molly or ecstasy, and speed. And if you go to the next slide, so now we're going to focus on fentanyl. So fentanyl, it has been embedded in the media now for the past, I believe, since like 2018. So one of the key drivers of the current overdose crisis is fentanyl, because it is in the drug supply, the street drug supply or illicit drug supply. So this was an unintended consequence of the restriction on prescription opioids. So people who were already dependent on these drugs and could no longer get them turned to street supply, the illicit drug supply, where fentanyl was present and in a majority of the drug supply. So if you focus on the yellow line, which represents fentanyl, you'll see that it starts to spike in the period between like 2018, 2019. It has continued a steady incline. And just something of note, fentanyl is a synthetic opioid. Fancy speak for it's a lab-produced opiate analog. It is much cheaper and more potent than naturally derived opiates like heroin and morphine. Um, Fentanyl has made its way into basically all parts of the unregulated drug supply, the illicit drug supply. And most notably, it has turned up in a majority of fake prescription pills like Xanax or oxycodone. And it also has been found in drugs being sold as cocaine, meth, MDA, and others. So when a person with no tolerance to opioids takes even a small amount of fentanyl, the impact can be deadly. And for those who do already use opioids, there's this difficulty, right? This challenge of measuring such a potential drug, and the unpredictability of street supplies has led to unintentional overdoses. So we can go to the next slide. Yes. So this is the big one. So people experiencing homelessness have been particularly hard by the overdose crisis. Homeless mortality data, it's not consistently tracked across the state, but there are counties that have collected this data and have been doing it consistently. And it shows that drug overdose is a leading, if not the leading cause of death among people experiencing homelessness. So we'll start off with Los Angeles, LA County. Overdose has been the #1 cause of death for people experiencing homelessness since 2017. 56% of deaths experiencing homelessness in 2020 were due to overdose, and 2017, 18, and 19. People experiencing homelessness were 36 times more likely to die of a drug overdose than people in the general LA County population. I want to read that again because that's a punch. For the combined years of 2017, 18, and 19, people experiencing homelessness were 36 times more likely to die of a drug overdose than people in the general LA County population. In San Francisco, overdose made up 86% of deaths among people experiencing homelessness in 2020, and that doubled from the year before. And if you live in the Bay Area, if we have some Bay Area folks, you've probably heard some reporting from news outlets that more people died from overdose in San Francisco in 2020 than died from COVID-19. It says that let's see, my internet might be
It's a little
unstable.
better now, Laura.
Oh, it's better? Okay, cool. Okay. All right. So yeah, in San Francisco, it was reported, it has been consistently reported that more people died from overdose in San Francisco in 2020 than died from COVID-19. And you'll hear shortly during our discussion about why that may not be a coincidence. And in Sacramento and Alameda counties, they've also found that overdose ranked #1 and #4 in all-cause mortality in people experiencing homelessness. So we do believe other counties would have similar findings if homeless mortality data was consistently tracked. Yes, next slide, please.
So thanks, Loris. So as Loris just talked about, the new prevalence of fentanyl and its analogs in the drug supply aren't the only factor driving these increased overdoses, though. As we all know, COVID left public health officials, social services really scrambling for ways to keep people safe from this virus, right? And as we know, one of the key recommendations for stopping the spread of COVID-19 is for people with infections, exposure, or heightened risk of complications to self-isolate. Obviously, if you are living on the street or in a tent or in your car and with other people, it's really hard to do that. Or even in shelters, as we know. So a whole lot of cities and counties around California mobilized to repurpose hotels to allow people experiencing homelessness or who were otherwise unable to safely isolate indoors to do that. But for people who use drugs, increased isolation, both in and out of shelter in place hotels, meant that if they had been accustomed to using with other people who could watch out for them, they were now suddenly finding themselves having to use alone in their rooms, so that when they overdosed, there was no one there to intervene. Really tragically, this is one of the key reasons why in cities like San Francisco, which, they moved really quickly to get people into safe, non-congregate shelter settings, but they still managed to experience such massive overdose loss in 2020 and 2021. So the other thing about this, of course, is that this isn't actually a new problem. Again, I'm talking to a room full of people who really know the situation, but moving into single occupancy rooms and other settings where isolation is common has long been linked to increased rates of fatal overdose. Advocates have pointed to this as a really strong argument for safe consumption facilities where people are able to use under the supervision of professionals who can intervene in case there is an overdose that occurs. So let's go to the next slide, please. So we know it can be really tricky to balance the importance of providing a private space for your clients while also keeping them safe from fatal overdose. So let's just take a few minutes. And again, we're going to use the chat and just think through a few of the ways that programs might be able to start mitigating the risks of isolation while still keeping people safe from both infection and overdose. So if you can just share your thoughts really briefly, and then we'll start looking at it. So, okay, so increased education. It says cost. I'm not totally sure what that means, but oh, and I do want to add, there's a lot of great questions in the chat, and we'll definitely have time for those toward the end. I do want to add like just something while you're answering this question, because somebody asked why there aren't stats for San Diego.
Oh, thank you.
The reality is that there are not mortality stats for people experiencing homelessness for most counties in California. And that is something that me, as a homelessness specialist here at CDPH, Molly and I are working really, really hard to change that, but it's going to take a few years. But yeah, there has been no consistent data collection. One of the resources I'm going to share out with you in the follow-up email, and yes, everyone will be getting these slides as well as a recording of this in a follow-up email. As long as you registered for the webinar with that email address, you'll get it. But we're going to be sharing a toolkit from the Housing or Healthcare for the Homeless National on how to get better at collecting mortality statistics and reporting those. So I don't want to get off on a tangent. I see decriminalization, going back to our question here, bringing awareness to the issue, fund more harm reduction programs. That's right. Oh, sorry, my alarm. Harm reduction. Yes. 2 people in each room, daily check-ins, wellness checks, community spaces. You guys really know your stuff, which is great. I'm going to just share a few others. Somebody had mentioned fentanyl test strip distribution, and having conversations. So I also want to point out there is a really great hotline, and we're going to share this in the follow-up as well, called Never Use Alone. So if there is somebody who is in their room or is in a space without anyone else to keep an eye on them, they can call a number. They create a little pre-planned safety plan. They'll leave their door unlocked, and there will be somebody there on the phone with that person to make sure that they stay alert enough. And if that person goes out, the emergency plan gets set into place. So I just want to give a plug for that incredible program. We'll share the phone number. It's an 800 number that people can call. There's similarly is an app called the Brave app, and Lauren can talk a little bit more about some of how that works. But yeah, we want to point out, like, as an agency, if you can also have an open door or amnesty policy for clients who are going to seek help to prevent or reverse an overdose, whether that be for themselves or somebody else, it can go a long way to being able to not only increase the trust that that person's going to have with you and your staff, but save lives, right? It's that simple. Having buddy systems for people to check in on each other if they're going to use that maybe don't involve staff, if they don't necessarily want to have that relationship. And then, of course, the thing we're going to really talk the most about today is training staff and residents on how to reverse an opioid overdose. So let's go ahead and look at the next slide. Okay, So let's just talk really quickly about naloxone. So what is naloxone? How does it work? So naloxone is considered a quote unquote rescue drug. It can be administered in a lot of ways. The two most common forms are an injectable liquid and a nasal spray. So naloxone is what we call an opioid agonist. It means that once it gets into the body, it quickly finds and binds to the opioid receptors in the brain. In fact, it is more powerful than the opioids themselves. And so it will actually kick out any opioids that are resting in those opioid receptors. And it kind of stays there, but it doesn't cause a high, which is interesting. And it does not cause harm to somebody who is not experiencing an opioid overdose. So we really strongly recommend administering naloxone, regardless of whether or not you know the type of drug that was taken if there is an overdose happening. It does usually work to reverse an overdose within 2 to 4 minutes. Sometimes it can take multiple doses, and we're starting to see this with some of the stronger fentanyl or analogs. That's why it's also important to have multiple doses on hand. And regardless of whether or not you have it, it is really crucial to remember to give a victim rescue breathing to make sure that their brain is still receiving enough oxygen to stay alive and okay once that overdose event is over. Let's look at the next slide, please. It's over to you, Loris.
Yes, thank you. I was combing the chat. So we're going to talk about naloxone in its two formats. So in the US, there are two. There's IM or intramuscular, also known as injectable, and also a nasal spray. So both work quickly and effectively to reverse an opioid overdose. But there are some considerations to bear in mind. The IM naloxone or the injectable naloxone, excuse me, it's been around for decades. And, people who have a longer history of injection drugs may be more comfortable and familiar with this form of naloxone. And with the injectable, it's easier to control the dosage. And some experienced users only give a partial dose at first to try to prevent the extreme discomfort of withdrawal. And most importantly, injectable naloxone, it's cheaper. It's cheaper to obtain since the patent expired, and it typically ranges between $1 and $4 per dose. Nasal naloxone, it is a newer product and is more expensive. It ranges around $22 to $60 wholesale, and even up to $120 retail. And nasal has been like the most accepted or chosen form when the person who will be using it is not quite familiar with syringes or uncomfortable with using syringes. Nasal naloxone works just as well as the injectable version, even if the person is stopping the spray membranes in their nose. Bottom line, both are excellent options for reversing an overdose when used correctly. And next slide, please.
And Loris, you were cutting out a tiny bit more again, but I don't think there's anything you can do about that. I'm really sorry, but just to let you know.
Okay.
But maybe
Thank
just
you.
talk extra slow so that it can keep up with you. I don't know.
Okay. I'll try to do that. Okay. Something it's important to remember that naloxone only works on opiate overdoses. So it will not reverse an overdose of drugs like stimulants, like cocaine, methamphetamine, benzos. So most fatal overdoses as well involve more than one type of drug. So it's always worth giving naloxone in case there are opioids in the mix. And something of note here in California, what we have been hearing, and we've collected data around it, harm reduction programs are seeing people who use more than one drug, using opioids and stimulus. And what we're also seeing too is that the average person who utilizes harm reduction programs like syringe access services, their primary route of administration is smoking. So that's something to be mindful of. And so a lot of pills that are made and sold in the street actually contain fentanyl. People who are new to drug use have overdosed on pills because they don't realize they were actually taking fentanyl. Again, the unpredictability of the current unregulated illicit drug supply is another reason why it's important to call first responders, right, as quickly as possible. And it's also important to note too that other types of drugs can trigger overdose. There's overramping with stimulant use like cocaine and methamphetamine, as well as newer drugs that are often again combined with opioids. And that includes benzos and xylazine, which I'm sure some of you have been hearing more frequently. Next slide, please. Yes, and xylazine is the sedative. Thank you, Pike. So yeah, so when we here at CDPH hear from folks who are interested in starting, or service providers who are interested in starting, naloxone distribution, we often, the first question that gets asked are like the legal ramifications, the liability concerns. And so we definitely want to discuss these in more depth, but I'd like to first dispel a few misconceptions. Naloxone does not cause a high. It's not addictive, and it does not have any street values. Keeping it on site pose a security risk. And giving a person naloxone if they're not actually overdosing on opioids should not cause them harm, except in the rare possibility of an allergic reaction. So pharmacists are allowed to give naloxone with doctor's prescription. And it is a recommended best practice to give naloxone to patients who use opiate-based pain medication. And in order to make it as easy as possible for programs to get started, California has a standing order that you can obtain. You sign up for the Naloxone Distribution Project, a resource that we'll talk about a bit later. And lastly, there are some specific statutory protections for non-medical professionals to possess and administer naloxone. Most of you, I'm sure, have heard about the Good Samaritan law that provides limited protection for arrest, charge, and persecution for people who seek emergency medical assistance at the scene of a suspected drug overdose. So we do understand as well that there can be some confusion when it feels as though federal requirements or policy might contradict that. So we acknowledge that there is a tension too between housing first and requirements for a drug-free workplace or a no tolerance policy for drugs on the premises. So with that being said, we contend that allowing a client to die from a preventable overdose represents a far greater threat of liability than does having naloxone on hand and ready. Next slide, please.
Actually, really quickly, Laura, since we're already on this, there was a great question in the chat. Can you speak really quickly to somebody had said, is there any legal liability for giving out fentanyl test strips? Can you talk about that a little bit?
So there are currently no legal liabilities as it relates to fentanyl test strip because it's seen as a harm reduction tool, a prevention strategy to prevent overdose deaths. And I'm going to have you pick up or piggyback on that, Pike, while I plug in my charger.
Yeah, thanks. No worries. So one thing that we have seen, so some places consider a fentanyl test strip to be drug paraphernalia because it is testing for drugs. I haven't personally heard of anyone getting arrested for such a thing. That being said, with an influx of new, more conservative district attorneys or just different policing practices in different locations, it really varies. So for example, in San Francisco for a long time, paraphernalia, including pipes, was completely, and syringes for that matter, was not considered citation or arrest worthy. With their new DA, that is no longer true. We have been hearing reports of people who not necessarily people working at syringe exchange, but people who are participants at a syringe exchange getting cited, getting ticketed for having either new syringes or having pipes on them, which isn't supposed to be happening legally. California state law has explicitly prohibited prosecution for that. Doesn't mean our people aren't going to get messed with, though. Loris, do you want to say anything else on that?
Yeah, just one small note, as well as, so California has law. We have law that states that any drug-using material that CDPH deems is a prevention strategy to prevent infectious disease should not be considered drug paraphernalia. And the supplies that we provide through our harm reduction clearinghouse, those materials apply, and fentanyl test strips are included. So I saw Lucy's question about fentanyl test strips were decriminalized in California. So that's and also like the liability considerations are test strips in California.
Thank you. So great questions in the chat, everyone. I know I'm really sorry I can't get to all of them right now, but I do hope that we can like scroll back up and talk more about this once the Q&A is really going. So we're coming to that part very soon. But I just want to really talk a little bit about some fundamental skills that staff members are going to need to be able to successfully curb fatal overdose in programs. So first, as we've already talked about, we highly encourage you to train your staff on how to recognize and respond to an overdose. We're going to share out some free resources for training your staff at the end of this webinar. Also, I noticed that the amazing Allie Hayes put in the chat a link to a video on how to do this. So feel free to like click that link and open that up because I'm sure if she recommends it, it's great. There's also several excellent online trainings that are paid or free. So after this, when we send out the follow-up email, all of that will be included. So don't worry too much about like trying to furiously write things down. Staff members should also really be able to either train and supply clients with naloxone themselves directly, or be able to confidently direct them to a local harm reduction program that can equip them with those needed skills and supplies. People who work in syringe service programs, which we like to call harm reduction programs because they now aren't just about syringes anymore, especially like Laura said, many people are smoking rather than injecting. But the folks who staff those should be able to teach people how to use Narcan or naloxone. Additionally, staff should be able to share information on where clients can access other harm reduction supplies, exactly like I'm just talking about. So sterile syringes, could be smoking equipment, although not everywhere, fentanyl test strips, wound care supplies, right? There's all kinds of really important harm mitigation supplies that they can get there. Your staff should be trained on how to have these conversations with clients in such a way that the clients feel safe and are safe to disclose any potential risk that they face without being afraid of reprisal, especially, you know, if I'm afraid I'm going to get kicked out of my housing for being honest with you about my risk, I'm probably not going to be honest with you about my risk, right? And finally, the National Harm Reduction Coalition has free online trainings available to meet most of these needs. Again, those links will be at the end. So let's go to the next slide. And without further ado, I'm really thrilled and grateful to be able to present our panelists. So each of these people brings a wealth of expertise on these topics. So with us today, we have Raven Hoops, we have Lori Miller, Emily Pomerantz, Dr. Matthew Baer, and Lauren Hall. I'm going to go ahead and turn it over to them now to let themselves do a quick introduction. So if you all want to come on camera and off mute, that would be awesome. You want to start us off, Raven?
Yeah, hey everybody, I am Raven, and you can use any pronoun that compels you with me. I am the coordinator of all things harm reduction based at Hill Country Health and Wellness Center in Shasta County, across Shasta County, but I happen to be based in Redding, California. Thanks for having me.
And hi, everyone. I'm Lori Miller. I'm a division manager over the Substance Use Prevention and Treatment Unit for Sacramento County Department of Health Services, and my pronouns are she and her. And I oversee all of the substance use prevention and treatment across the county.
Hi, everyone. I'm Emily Pomerantz. Pronouns are she, her. I'm the program manager of the Harm Reduction Institute Syringe Exchange Program in Santa Ana, and I'm happy to be here.
Hey, good morning, everyone. I'm Dr. Matthew Baer. I'm the medical director of special populations at Clinica Sierra Vista here in Bakersfield, California. I head up our street medicine team, as well as our MAT program for patients with opioid use disorder. Pleasure.
Hi, I'm Lauren Hall. I'm the Executive Director of Delivering Innovation Supportive Housing. We operate permanent supportive housing in San Francisco, and I am the lead on our harm reduction programming, and I'm glad to be here.
Thank you so much, everybody. We're really thrilled to have you here. So let's go ahead and start with Lori. I know Lori has a few slides to share about the work that's happening in Sacramento.
Yeah, thank you. First, want to thank all of you who are viewing this today for just caring about this issue, and certainly this vulnerable homeless population that we're working with. So this is a great conversation to have, and I'm really glad to be part of it. So in Sacramento County, we are addressing the fentanyl poisoning and overdose crisis in a variety of different ways. And so I wanted to go over those with you, and hopefully something resonates for you and your county in order to have some strategies to combat this issue. So first of all, we have partnered obviously with the Department of Healthcare Services on their naloxone distribution program. And we have placed Narcan or naloxone in most of our public facing lobbies across Sacramento County, because the goal is to make Narcan as much available and accessible to anyone in our community. And so we're trying to make it convenient for people to know where to get it, to know where to access it. Secondly, our County Department of Health Services has partnered with our Sacramento County District Attorney's Office on a campaign called One Pill Can Kill. And you've probably heard of this type of campaign across the country. The DEA has a similarly named campaigns, and other counties do as well. But you can access resources at onepillcankillsac.com. And then I am part of the leadership team of our Sacramento County Opioid Coalition. So if you don't have a coalition in your county to address opioids, I strongly suggest, getting a team together, getting some stakeholders together to really talk about this issue. And then we also are part of what is called the California Opioid Prevention Network. And we have been partnering with them for a couple of years now since this opioid crisis has come to be. And this is where we kind of look at innovative strategies, best practices, really tapping into other counties and what they're doing to enhance the work we're doing here in Sacramento. And again, we have a variety of different community events. We've developed several informational sheets on our websites and through our Opioid Coalition resource pages, and the onepillcankillsac.com pages as well, if anybody's interested in taking a look at those. And then we've expanded our medication-assisted treatment programming across the county. Next slide, please. So I think this is just kind of a different way of alerting all of you to some of the ways that you can address fentanyl poisoning or opioid overdose in your county. So again, through the naloxone distribution project, putting it anywhere that people can access it easily. It's been a huge challenge from what I'm hearing across counties and people not knowing where to get it. And I know that others on this call are going to be letting you know kind of some simple ways of being able to order it, going through the state's program or other places within the community. Next slide, please. So in addition to some of those ways I've already talked about, I wanted to talk about a new project that we have in Sacramento County called the HEART Team. It's the Homeless Encampment and Response Team. And so this is a team that goes out into various parts of our county in Sacramento, where we're seeing, homeless encampments throughout the county. It's staffed by counselors and peers. And the goal is really to engage people and to engage and build trust and build rapport so that people are, feel safer to access some of the treatment services for behavioral health or substance use needs. We also train these individuals to go out there and talk about the dangers of fentanyl, talk about where to access other types of services, harm reduction services, in addition to behavioral health services. We're providing the training around Narcan. We're linking them to other ancillary services and certainly looking at trying to provide shelter and long-term housing for people out there. And this is a coordinated effort with our Office of Homeless Initiatives and our Department of Human Assistance. Next slide, please. Okay, and if you have any questions, feel free to reach out.
Thank you so much, Lori. That was really, really fantastic overview. I appreciate it. So now I'm going to actually turn our earlier question over to our panelists. And starting with Lauren, especially. So going back to our earlier question, how can homeless service providers mitigate the elevated risk of overdose when people who use drugs are placed in non-congregate, so meaning single unit or single room housing? Lauren, you want to take us away?
Sure, thank you so much. So again, I operate about almost 900 units of supportive housing. It's all single room occupancy in San Francisco. And so as folks talked about, a big part of our work is really around trying to educate staff and residents around overdose. But I think we started out in about 2016, recognizing that we didn't have the tools we needed to support folks who were at risk of overdose. And so we were working with the DOPE project, part of the National Harm Reduction Coalition, early on to have 24/7 access to Narcan. So we started our work there. And I think as the crisis has changed with fentanyl, we've realized that just having Narcan available was really not enough. And so we've worked with, we have kind of a 4-part strategy that I want to talk through that has been helpful for us in supportive housing. And I'm going to go pretty quickly through it, but I'm certainly happy to talk more about it, and you'll get my contact information. So if you could go to the next slide, that would be great. So, as was mentioned earlier, we were seeing when people were coming inside, many had been using on the streets and had been able to keep themselves safe. And when they were coming inside, certainly as the pandemic was really ramping up, we were very concerned about the rate of overdose that we were seeing in our buildings. And the focus of San Francisco was really on, we need to deal with COVID. Sort of all the resources went that way. So as a housing provider, we really recognized that we needed to figure out a way to keep our residents safe. So as I noted before, we were getting our nasal naloxone from the state program, which has been wonderful. We had that at the front desks, and we decided that we needed to have it everywhere in the building. And so really saturating the building with Narcan, having dispensers on every hallway with rescue breathing masks, and also looking at how do we get it in the hands of residents. As well, we can train all of our staff to really be overdose specialists. There's always going to be mistrust with folks that are actually running the housing. As a landlord, I have to recognize that I feel like I've been a harm reductionist for the last 30 years, but still someone's not going to come to me in the same way they'll come to a peer. So I'll get more to that when we talk to the peer overdose specialists. We also wanted to be able to detect overdoses. So as Pike had mentioned earlier, there's a technology company called the Brave Technologies. It's an amazing organization that tries to utilize technology to help identify overdose. So we installed at the Minnalee, which is one of our sites, we installed these Brave buttons in every unit. And you basically can push the button and it alerts the front desk that you need to be checked on in a few minutes or that you need help right away. So the idea is that if someone is going to use, isn't totally sure about their supply, that somebody knows to come and check on them. So putting that into action, and then also really working closely with our friends at DOPE and the National Harm Reduction Coalition to try to replicate what had been done in Vancouver with the Toro SOO project, to really provide intensive training with staff and residents around overdose reversal, how to recognize the signs, and most importantly, and this is the most important part of our program, is to provide a role for residents in the community to actually lead this effort. And so I think one of the lessons that we learned is we were trying to do so much to create all of this structure, yet we were missing the critical link of having people who use actually be recognized as the experts in the building and to step away. And so to really try to scaffold up a support program where we identified, well, the residents identified 6 folks who lived in this building. It was a 50-unit SRO who became the peer overdose specialist. They received stipends to do that work. They had cases of Narcan in their unit. They were able to support our team in responding to Brave button pushes and really create a community-based response so that if someone never wanted to come and talk to staff about their use, they knew who was in the building, who could help get them Narcan quickly, could help keep their eye out if they saw someone coming in who clearly was going to use, who maybe they didn't know as someone who was really experienced, they would go and check on those folks. So this kind of 4-part program is what we've been piloting at the Minnalee, and we'd like to really make it kind of the foundation of supportive housing, overdose response policy in San Francisco, in the state. I think each part of this really has provided a critical piece. If you can go to the next slide, we were fortunate to have Dr. Kelly Knight and her team part of an evaluation of this project. They were hired by the San Francisco Department of Public Health to really look at the SRO project, which is with the peer training and response. And so they looked at this, and I think just thinking about, to me, some of the most important part is that the specialists themselves really learned that their expertise was incredibly valuable, and so could sort of move away from the shame of drug use and the shame of having of this, you know, being able to do this, to bring it to the light and say, actually, I'm the expert, so you all can step aside and let me do what I know how to do. Because so many as we know, overdose reversals out in the community, that's who's saving lives. It's not the police, it's not us as service providers, it's really, you know, sister and brother users who are together and who are really keeping each other safe. We also found that it really helped facilitate rapport and conversation between our staff and the residents. While our staff were certainly wanting to do the right thing, I think there's always a level of, you know, if someone is not a drug user themselves or doesn't have that experience, they're going to bring not only their own judgment, but their own fear around administering Narcan, their own fear around, you know, kind of what will happen and the risk of whether they'll be liable if something doesn't go well. So it really helped us open up a conversation around how to do this work together as a community. We've certainly seen, compared to our other sites, while there is the challenge of data collection on how many overdoses were reversed, in some cases they're not always reported when it's successful. We haven't seen any overdose death in this particular project in the last year compared to other sites of ours where we only have Narcan, and we still are seeing a fairly high rate of death with fentanyl. Fentanyl can kill very quickly if there isn't that sort of community really recognition around that this is a crisis and that people really need to act quickly. We're seeing that we still need to do more in our other sites. So that's kind of a lot of information, but I just wanted to really emphasize, no matter what you do in your program, please engage specialists, find ways to pay them stipends, really to recognize the expertise and the knowledge that the community of people who use substances can offer to your program. I see a question about the Brave sensors. I just wanted to say quickly, we haven't used the sensors. We're looking at them. Really, we started with the buttons as we felt like those were a way that a technology that we could test out. And as we get more funding to do more things in our buildings, we're looking at whether we can use the sensors. We have some shared restrooms in some of our buildings where we'd like to have those, but we were seeing the highest rate of death actually in people's rooms. So that's where we started. And then I just wanted to thank you for sharing this quote. I'm not sure if Dr. Knight is on the call. I know she had wanted to be, but I think part of it too is that this really opened up a way for the community to kind of hold each other when there's such stress and such a high level of loss. And so many the specialists provided sort of a network of support for each other and other residents for when there was a fatal overdose, that there was a way to recover from that, and also ways for people just to talk to each other about kind of the past trauma that they'd had around experiencing overdose. And then knowing, like, I can go and talk to that person. I can also go talk to that person that I need Narcan, or that I want more information about how to use safely. So again, it's been a really successful program for us, and I hope others will consider not only getting your staff trained, getting Narcan on site, but continuing to push yourselves to really create ways that the folks who are using can lead the response.
Lauren, that's so powerful. Thank you so much for sharing your amazing work. So yeah, I think I want to turn it over to Raven to sort of speak next on, so right, like the quote says, you know, overdose response is traumatizing. It may not be scary, but it gets in you. And that's whether you succeed at reversing the overdose, or worse yet, if you do not, right? Either way, it's a pretty intense experience to go through. So Raven, do you want to sort of speak a little bit to this next question of what can programs do to prepare and support both their staff and their participants to reverse overdoses? And that includes aftercare. So just bearing in mind that they may not always be able to successfully reverse that overdose.
Yeah, sure. Thanks, Peg. I first just want to say, this question, I feel like Lauren, you really touched on one of the most important pieces, and that's the idea of honoring people who walk the path, and really making space for those of us who have lived it to be a part of the solution, because in reality, that's what's always been going on. So that's really where I start. I come from places where you pretty much only employ people who would have already probably been through this experience prior to their employment. And for the first time, I'm at an FQHC where there are far less people with that experience. And so I've learned that there's more that needs to be taught in these environments. So if you don't already have the experts in the room, then there is a need for real preparation. So the place where I start with this, or have started with this, is to, in order to honor that idea that we've always been out saving each other, and really know what to do, is to start by collecting the knowledge that is already existent in either your current staff and or honoring the experience that already exists in the person who you're about to train. So I typically just start with, are you familiar with how to use either IM or nasal naloxone, and gather that and use that to kind of be your jumping point of what needs to be filled in. From there, you just need to fill in the gaps. Obviously, if there's no knowledge and no expertise in the room, you need to start at the beginning. But if there is, then engage that knowledge and really honor it and the experiences those folks have been through. So if you're starting at the very beginning of this process, Pike went through and Loris went through a lot of what would be entailed in like the technical training of teaching someone. So I start, if it's a full scale training, I'm starting with just what is an overdose. It's surprising sometimes to me how much people can't define that. And so just to really know exactly what we're talking about, knowing exactly what naloxone is and what it isn't, and the relationship between those two things is so important. And then you're walking people through prevention, recognition, and response, not to skip recognition, because I think one of the important things that I've come across living in a more conservative with less harm reduction services available in the community is that there is still sort of an old school air about using naloxone where it can actually be turned into a weapon. And so I think it's really important to recognize that there's a lot of misinformation out there. So making sure that you're preparing your staff and the people coming in to be gentle with the use of naloxone. Yes, we want to use it. We want to revive people. But we have a lot of folks who are getting the message that you need 5 to 8 shots of naloxone to bring someone back to life. And there may actually be some panic in that, and we're not waiting long enough for it to take effect. And people, there's not a lot of harm that comes from using naloxone, but for the person who's using the drugs, it is painful. So we want to honor that. And then I just, the technical training obviously is important. That's how we're going to revive people and get people competent in being able to teach the message. But I think what is some of the most important stuff is, how do you work with communicating with 911? That's really important, especially in smaller communities. So really speaking to how to engage them if necessary, how to talk with them, what do you say, what you don't say. And then trauma times 2. The person who just overdosed has been through a traumatic experience, and you as the responder has been through a traumatic experience. So we have to be paying attention to that aftercare, as that quote said, right? That most important voice said, is really like, okay, now we've been through this thing, whether we survived or not, whoever's still standing, we've all kind of experienced it. So we need to be addressing that issue as well. So how do I handle that here? So if it's about me dealing with staff members, then there's an immediate check-in with the supervisor. If I'm not their supervisor, they also typically will have a check-in with me as well, wherein that individual who responded is offered support that may include direct counseling. It may just be a debrief. It may include time off. It also might include shift responsibilities. So if they would typically be working with this individual again, and they feel that they're not able to do that in the moment, or they're just experiencing too much trauma back and forth with the things that they're running into, maybe a break from those particular responsibilities in their role. So we try to cater it directly to what they say they need in that response. And then also we have this sort of unique thing at our organization called decompression sessions. We have a gentleman who is available to our staff at any time to schedule for free 45 minutes to hour-long decompression sessions of anything that's going on in work or their life, where they just need a timeout to talk through some of that stuff and have somebody as a backup. So there's a lot of layers to continuing support, and then checking for any need for further training. Once somebody goes through it, everybody thinks that they're ready for this after they get trained, or maybe they don't think it, they're still a little stressed out. But either way, you know, you think you got the training and you're ready for it. You have no idea how you're going to feel after you experience a trauma, or assisting someone back to life, or perhaps assisting them over that bridge because they didn't make it, right? And it's a huge experience. So a lot of times what I find is that people come away from it going, I just, you know, I fight or flighted into response, but here's where the holes were. And I can, through a conversation, I can help to add training where I can see that it could have maybe gone a little bit either smoother, either, you know, internally, even how they feel about it. And then lastly, I just, and then of course, we also are offering aftercare to the person who actually experienced the overdose. So immediate supports if desired, if a person is in a place where they need immediate support or care after the overdose. But also we have a street outreach team and other staff who will go out in the future to try to make contact with that individual, check in, and build on the harm reduction conversation. What are the things that are leading up to overdose for this individual? How can we assist in other ways so that maybe we prevent it in the future? And lastly, I'll just say, to jump off the mic here, one of the most important areas that I spend a ton of time training, especially in this new environment I find myself in, is please do not forget to include your extended harm reduction training and the destigmatization of this conversation. Because if people don't respectfully respond to overdoses, then we have secondary problems and secondary traumas that sort of perpetuate after the initial event. So please teach respectful and realistic information when you go to tackle this with your staff, your community, and anyone else that you end up engaging. Yeah, so that's what I got on that one. Thank you.
Hey, Raven, I just wanted, I haven't been to church in a long time, but it feels like hallelujah is sort of the right thing to say after all of that. I think that was incredibly poignant and informed. And I don't even know what anyone could add on after all of that. So thank you, genuinely thank you for that. One thing I do want to potentially add in what can be done afterwards, and I think is really important, is talking to that patient, if they do survive, about seeking medication-assisted treatment for the opioid use disorder, because that has a well-demonstrated reduction in mortality. In our homeless patients, we try to encourage using buprenorphine products as much as we can, given the medication's affinity for specific receptors. It has its own protective benefits. So patients who are on these medications have a much less likelihood of overdosing to begin with. So other than that, I have nothing to add, Raven, because I think you just nailed it.
Raven, I just think that was an amazing response. I would just say a couple of things that we should all pay attention to is that time is of the essence when it comes to administering Narcan. Fentanyl kills, very, very fast. And so on average, it takes EMS about 7 minutes to arrive to a scene, and a person can die in that amount of time. And so time is of the essence, certainly. And then the second thing I would say is about as we're preparing people for somebody who may or may not make it through fentanyl poisoning or opioid overdose, is that they may come out of the overdose and respond very differently. Some people may come out of the overdose and their breathing is restored and they start crying or they're very emotional. Other people, it could be violent. And so maybe we could speak to that a little bit in terms of preparing people, who would engage.
And we're a small team in Orange County. There's 4 of us that work with our Narcan distribution and the Harm Reduction Institute. And we just really try to practice compassion and empathy and really meeting our participants where they're at. Unfortunately, there's not a ton of aftercare resources for our participants in the Orange County area. So it's very difficult for us to continue to keep a positive mindset for our participants, but we do so with grace and empathy, and we do the best that we can in our area. Granted, most of our participants are on Medi-Cal, and the options for them are not huge. So when they do experience an overdose, 99% of the time they do go back to using, and we offer medicated assistant treatment as well. But unfortunately, there's not a lot of housing offered or detox and residential treatment for our participants. So the best bet for them is they're referred to College Hospital, which, after a couple of hours or a couple of days, are released right back onto the streets. So our team is very empathetic, compassionate, loving, engaging. We definitely go above and beyond to make sure that our folks are feeling heard and important especially after an overdose.
That's so beautifully said, everybody. Thank you so much for sharing your answers to that question. That's fabulous. And it looks like, Emily, you've got a DM in the chat. So I'll share that with you later. Okay, let's go ahead and move to our second question. And this is for anybody who cares to start us off, but can you share a major or memorable challenge that surfaced during the implementation of overdose reversal or overdose prevention work? And how did you address it? And I'll just open the floor for whichever of our panelists wants to share.
I think, again, this is Lauren with DISH. One of the things that I feel like we didn't do, the good job on right in the beginning was figuring out how to have residents feel like they could really be part of the process. And I know I spoke about this, but I think what we've been learning is those kind of joint trainings where residents and staff are together, like for the stigma training or for harm reduction training or the, Narcan itself, has really had a kind of beautiful benefit of opening staff's minds who maybe are not from a using community to really kind of address stigma and hear about why residents use, and if people feel safe enough talking about that, and also just to make sure that they're learning this together, because I do feel like there's part of the implementation, you really have to get everybody on board, and that's hard to do. And a lot of people that work in the field are bringing different experiences. Maybe they're in recovery and they're feeling like residents need to follow the path they followed, or vice versa, right? There's all these different things that people are bringing every day. So trying to get folks to come together and really talk about it, and to make every interaction with a resident or a staff an opportunity to kind of build that connection and empathy. So when we do our intake interviews, really trying to talk to people about, what do you need to be safe in housing? Not like, do you whatever, like, what do you need to be safe? What do you as a staff person need to have to feel safe if you are the one who's administering the Narcan? And really trying to sort of open up similar conversations and build that compassion for each other. We certainly had some technological challenges with relying on the buttons, or, people like there's a phone, like if you press the button, it calls a phone, someone stole the phone, right? There's like all these things that happen. So some of those were not so memorable, except that you just really have to have solid logistics in place whenever you implement these programs, and to anticipate that you're going to have bumps in the road and need to continue to refine, and the training needs to continue because there's going to be turnover of staff. So really being dedicated and having a dedicated staff lead for this work it's not really something you can just kind of administer without having someone who has the bandwidth to pay attention to it and really make it work.
I'll add a couple of things here too, in terms of some challenges we experienced in Sacramento. Going through the California Department of Healthcare Services naloxone distribution project, sometimes there can be a delay in the shipment of the naloxone to your county or to your area. And so that was very frustrating to us when we had a lot of community events, or we had harm reduction organizations or community-based providers that were really wanting to have this in place. So just be prepared that there is a time frame, typically about 4 to 8 weeks to get the shipment out is what we've experienced. So some frustrations around there. And as much as it is so important to have it available everywhere and accessible everywhere, in community-based providers, medication assisted treatment providers, harm reduction providers, it's important to get it out to the people, bring it to the people that need it, rather than expect them to go somewhere to get it. And so part of our HEART team, or our HEART program, we're out there in the encampments, we're going into the community to provide it to them.
Yeah, we're doing the same thing too. Since our syringe program shut down about 9 months ago, we're doing a lot more street outreach. We make our intramuscular Narcan kits, and then we go and pass them out. We supply a lot of the encampments in Orange County. We're expanding a little bit more into Anaheim, but we've faced that problem as well, where we will apply for the nasal Narcan and it takes about 4 weeks for the application to even get looked at, and then another 2 to 3 weeks before we get our shipment. So when we transitioned to intramuscular, a lot of our participants had a really difficult time going from nasal to intramuscular, and a lot of them rejected the intramuscular, and then finally they came around after a while, and us really showing them, hey, this is how you do it, training our participants, being patient with them. It's a little bit more challenging using the intramuscular than the nasal. And a majority of our folks are no longer using needles because they don't have access to them currently. So they didn't want to be walking around with them. We put them in sharps containers with a biohazard sticker on them with instructions inside. Unfortunately, the police department doesn't really care if it's Narcan or not, and are citing our folks for that. So we're really trying to work with that and doing everything we can to ensure that our folks aren't getting in any trouble for possessing Narcan. So that was a challenge that we experienced, and it's gotten a little bit better. But now that our nasal is coming back, we have the option of both. So
I was gonna add, since we're sort of talking about, and I know there's quite a few people on here who have maybe not yet implemented this service. So to speak to that a little bit, like I said, I come from a world of work where you just do whatever's the right thing to do, and you don't really contemplate it too much. You just do it. And I'm now part of a larger system and bureaucracy, and the challenges that I just want to speak to is, don't overthink this process. Don't overcomplicate it. This is, for a long time, this has been happening. We've been distributing naloxone for many, many years, whether that's above or below. It's been happening. It's not difficult. There's not a lot of risk going on here. So I would say that the things I ran into was the overthinking the process as I started to implement it, like me presenting it as, it's this simple, we just need to do this and then we're good, we're going, we're on it. So there was a lot of overthinking in like policy and procedure land, et cetera. And then also the thing I ran into that was new for me was addressing fears that exist in systematic problems and systematic training. So there's like a lot of perpetuating what might happen, the what ifs if we do this. Especially I find that in like medical provision, there's a lot of angst with things like licensing and things like that I'm not familiar with. I don't come with from that, so don't worry about that. But I ran into that where I just had to do a lot more kind of dispelling the myths and fears that are not necessary to be there. You can just do this. You can just implement this. Get your relationship started with CDPH and DHCS and all of the people who are supporting this stuff. in those ways, and don't try to control it. Like, remove your need or desire or whatever it says that keeps you in the box to control this, because again, the voice of the experts are the people on the street, on the people who are using, and the less control, the better. All to speak to, I have this phrase that comes up a lot when people are coming in new to harm reduction work, and this level of conversation is stop asking, because when you are asking, you're actually looking for the no's. You are actually going to create doors that close on you. And in effect, change happens when you show what works. So you have to show it, right? So change happens when you show what works. Nothing in harm reduction ever got done by asking. So just do the thing that's the right thing to do to keep our brothers and sisters and otherwise alive.
Yeah, Raven, as someone who also works in an FQHC system, that those barriers that come from senior clinical and stuff in terms of policies and procedures, it can be such a nightmare. So I absolutely hear what you say. I think I operate, and probably a lot of us operate, under this idea of do the right thing until you get caught, which is sort of the only way some of these things would happen. We're having the same problem in our street medicine efforts. We can give out Narcan. We have no issues. When we bring it back to the table and say, hey, we should have this at every single clinic, it's a ton of pushback. So I hear you. Again, I hear you.
You're right, Raven, in terms of like harm reduction organizations or community-based organizations or street outreach, totally agreeable. But when you're working for a county system, it's a little bit different, because there is that bureaucracy, there is that higher leadership approval process, or through your board of supervisors within your counties. And so unfortunately, counties do have to operate within those, but it's great that we can partner with, you know, our community-based organizations and others who can really get this out and move it more quickly.
Thank you all so much. That was such a fantastic wealth of knowledge that you shared. Let's look at the next question.
Yeah, I feel like we've touched on that. There's some things that we touched on with the next question.
Yeah, no, absolutely. So Loris, I'm going to turn this over to you.
Yeah, you all did share some really good nuggets about information to share with folks who are considering it or contemplating it. Is there any, like, we're going to start wrapping up the panel. So are there any last nuggets that you'd like to share for providers who are contemplating this? I heard, ask for forgiveness later. I heard Raven say, don't get caught up in the what ifs, like playing out scenarios, and get stuck in policy and procedure land. We do that a lot. But are there any other gems that you'd like to share with the group today?
Remember that this is ultimately about relationships. Like, we're all people. And so this is about, there's the harms and the risks and whatever, but this is about relationship building. This is about honoring human beings for who they are, no matter what they do. And so the more that you can stay focused on that and stay curious about, even whether it's your staff or the people that you're out serving, it's about relationships.
And remember that, the work that we're doing is so beautiful and so inspiring and so just amazing and incredible. And we're out here saving lives. And, I come from a treatment background where I worked in treatment for many years. And when I started working in harm reduction, having people come up to you saying it's because of your Narcan that I was able to save my brother, I was able to save my sister, just how powerful the movement is of what we're doing and the work that we do out there on the streets is, my heart is just so full. So anyone that's thinking about doing it, just know that, with all the bad stories that come, with people not surviving or, not making it, there are those good stories that come as well. And we are saving lives. That is what we are doing, and we are not going to stop. So
I think really elevating that story is so important. We have staff meetings and some of our desk clerks, right? They're like, I'm too scared to do this. And I see some in the chat, like, I would be so frightened. And then you have one who has saved a life who says, you know what? it's amazing. Like all you have to do is show up, and administer Narcan, and people get a second chance or a third chance or a 10th chance to really survive. And I think trying to elevate the successes is super important, and to help your staff recognize that, like for us, it's not necessarily mandatory. It's just like incredibly encouraged that people respond, and if they're the only one there and they do it and they succeed, to really celebrate that success. And even if they aren't successful, if somebody does not make it, to really celebrate that we tried, and we're all trying to wrap our arms around this crisis and just help people live another day. So I think really celebrating success is helpful.
And I would just say, just do it. Lift this issue up and get out there and take action, because overdose is 100% preventable. Education, awareness, partnerships are so critical in this process. And, all of us in our efforts to also reduce stigma around all of these areas. So definitely get out there, just do it.
Yeah, I'm hearing what's been a consistent theme throughout this discussion is what I like to call harm reduction, capital H, capital R, which is the philosophy, right? The principles, and harm reduction, little h, little r, which is the actual like activity, right, of naloxone distribution. And I'm hearing the importance of instilling, destigmatizing language of people first, like centering people first. And when service delivery is one thing, but then it's how you deliver that service is what I'm hearing consistently throughout this discussion, which is very important to remember the principles of harm reduction. Yes, okay. Thank you for that. We're going to close out now. If we can go to the next slide. We're going to close out with, I call this kind of like the gray area. So we wanted to talk a little bit about the potentially like more complicated subject around like providing naloxone on site, especially if your program does not allow on-site substance use, right? So we know that California Housing First principles mean that no one is supposed to be turned down or kicked out of housing just for their drug using, with the exception though of people staying in sober living substance use recovery programs. But this is not the same though as allowing use, right? And we've heard concerns that providing naloxone might send a message that drug use is acceptable in your program. So if y'all could just share like how you might address those concerns, and what are, if any, workarounds that you've heard of or you're already using yourself to balance, clients safe from overdose while trying to stay in compliance with other regulations about substance use on site. And anyone can take that question. And if there are any attendants that we have who'd like to chime in on that, please feel free to enter it in the chat.
I would just start with that it's prevention and education. And although, you may have some requirements that people are not supposed to be using, again, we know that happens. I mean, it's the reality of it. Here in Sacramento County, we had some projects called Project Room Key, where, folks were not supposed to be, bringing in substances or using substances on site, but we still had, caring team members that would have, Narcan available, fentanyl test strips available, other resources available in the event this does happen. It's preventative. It's 100% preventative. And I think that we still need to make sure that we have resources available.
Okay, I think for the sake of time, so we have about 10 minutes left, and we want to make sure that we cover our content and allow time for Q&A. So we're going to move on to that. If anyone.
Naloxone. So, first of all, Molly's going to be dropping some links in the chat, but again, this is all going to be shared out with you in the follow-up email. So don't stress if you're not, don't feel like you need to click all the links right now. It's totally fine. But there's a couple steps. And in fact, we even made a handy dandy step-by-step flyer, which will be shared with you in the follow-up email. So first thing you do is apply for your standing order for naloxone. CDPH has created a web page exactly for this purpose. It takes about 5 minutes for your program to apply. It does need to be completed by somebody with authority at your program. So it needs to be at least at like a director level, to make sure that there's no, weirdness happening on an interagency level. So make sure that you do have permission and authority to do that. You'll just fill out the application. And then once that piece is finished, you will go to step 2 and you are going to apply for the naloxone distribution project. Now, as it has been noted, there can be a real delay, right? We are just as vulnerable to supply chain issues as anybody else, and funding is not limitless, which is another reason why, if this is important to you, you should actually let your legislators know that they need to fund this stuff. But yeah, you want to basically fill out the application. Again, make sure that it is an authorized agency representative filling it out. You will need a valid business license, like FEIN number or your tax exempt letter. So just have all that stuff ready to go and at the time you apply. And again, it's not a long, terribly complicated application. We've tried to make it as streamlined for you as possible. And then make sure that you have a distribution plan, right? Like know how, to whom is it going to be available? Are you just ordering enough for your staff in the office? Are you ordering enough for your outreach workers to be providing it? Which, that would be in an ideal world, what we would really recommend. Who's gonna have it? Where's it gonna live? Does everyone know where it's stored? All of that, right? We have also an entire FAQ page available that will be in the links later. So let's go ahead and go to the next page. So some of the resources and tools that are available to you, there are a lot, thankfully, because we live in a state where people have been doing this work for a long time, and some of those legendary people are on this call right now. So I want to just give a shout out to everyone who's been in the trenches for years now. So for training, the National Harm Reduction Coalition has a fantastic 3-part training module on harm reduction, and it's free to everyone who lives in California. You can get a certificate of completion for each module. And the other thing that's really cool about it is that, yes, there is an overdose prevention and response module, but there's also modules on how to really positively engage people who are using drugs and what are the foundations of harm reduction. There's also CDPH quite some time ago made a little 11-minute explainer video. It's a little bit more buttoned up, as you might expect, but it's still, the information is valid and we recommend it. So feel free to check that out. Get Naloxone Now also has training modules. And then we've already talked about how to go ahead and order your naloxone. And then we also encourage you to please share with your participants where they can get other harm reduction supplies. So we will include a link to local syringe service site directory. And if you live in a location that does not have a local harm reduction program where they can go, there is a thing called the Next Distro, which is mail order supplies, including naloxone, including sterile syringes. There's all kinds of wound care supplies. They can get that delivered to an address, which is an incredible thing. And then last but not least, I want to make one more plug for the Never Use Alone hotline. And I know we're at time. Next slide. This is the most exciting thing. So I know you're all going to rush out and start applying right now. 1 month from now, we are going to offer a support call. Oh, we've got a poll too. So go ahead and take a poll. Let's pop that poll up, Molly, if you can. I want to know, how likely is it that your program is going to start working toward overdose prevention readiness in the next 30 days? I just want to see how inspired you all were by these incredible presenters. This is looking really good. We're at very likely to somewhat likely is in the lead. Let's do, okay, we've got 50%, 55%. All right, I'm going to close it in 5 seconds. 3, 2, 1. Okay, so there's a lot of folks who are about to embark on this journey, and we know it can be a little bit complicated. So as I said, let's go to the next slide. We are offering a support call. This is going to be an opportunity. We'll have some experts on the line, but we're also going to have you guys just all be able to come off mute, share your own experiences. If there's enough of you, we'll do breakout rooms And if it's successful and necessary, we can make this an ongoing offering, right? But we really want to make sure that we make this as accessible as we possibly can. So if you want to register, we can drop that link into the chat. This will also be available in the follow-up email. So there's going to be a million good resources in that. So keep an eye out for it. And yeah, I guess that's what I've got. I just wanted to say, like, massive shout out to everyone on our panel today. Thank you so much. Huge thanks to my fabulous colleagues, Loris and Molly Lund and Marjorie Katz, who have been, I know Marjorie and Molly have been behind the scenes making everything go smoothly today. And that's what we've got. Let's do our final page. This is how you get in touch with me and Loris. Everyone else's email is going to be in that follow-up email. So don't worry, you can keep in touch with all these amazing people. And I just, again, want to thank you all so much for being here. This has been a huge dream of mine, to be bringing these worlds of harm reduction and homelessness together a little more tightly. So just deep gratitude, you're saving lives. So with that, have a fabulous rest of your day and reach out with any questions.
Thanks all.